And so we're going to get started with the anterior view, so this is looking at the front of our patient. And so in the beginning of a structural exam, what you would do is you'd have your patient walk back and forth in front of you. And so when you're doing this, you're assessing their gait. Specifically, what you're looking for is stuff like their stride length. You're making sure that that's consistent. You're checking their arm swing. That's another big thing. You're also looking to see if their feet have any in-toeing or out-toeing, so in versus out-toeing. And finally, you're also checking to see if there's any pronation or supination of the feet. So once you've assessed gait, the next thing that you're going to do is overall from this anterior view, look at the skin of this patient. So do you notice any macules, any types of bruising or redness? So you're going to inspect the skin. Macules would be things like moles, bruises, redness, stuff like that. And you could also note any scars that you see on this patient or tattoos and just denote their locations. Next, what you do from the anterior view is you're going to check the patient's feet, and I try to do this in a systematic way so that you make sure you cover all your bases. We're basically going to start from the bottom of the patient, work our way up to the top. So on the feet, what you do is you palpate their arch. So right in here, you're going to be checking to see if they have pes cavus or pes planus. And so basically what that refers to is whether or not their arch is collapsed or if it's, hyperextended. And so if you do have anything that looks to be outside of normal limits, you would note that. So if their arch was way too high, you would say that that is pes cavus. If their arch was way too low, you would say that's pes planus. So pes planus cavus, question mark. Next up, what you're going to do during your exam is you're going to be looking at the patient's knees. And specifically what we care about are things like genu valgum or varus. And so what does that mean? So when you're looking at the patient's knees, you're going to note the distance between these two knees. If the patient's knees seem to be very stuck close together, like they're trying to hold in their pee or something, that would be genu valgum. And a way to remember this is you see gum in valgum. It's like you have some gum that's sticking their knees together. Another way of remembering this is to think of valley girls who are going to also be kind of trying to make that figure 8 look with their knees. And then in terms of genu varus, the way to think about this is there's a lot of air between those knees. So this is something that commonly you also see people say bow-legged. So if in a neutral stance, the patient's knees are very far apart, you would say they have genu varus, which would be the appropriate medical term to use in that instance. Up next, what you're going to check and palpate for is the rib contours. So we're moving up from the knees, and on the contours of our ribs, we're basically trying to make sure that the left and right sides of our patient are symmetric. And then I will note that it is kind of tricky when you're actually doing this on a real live person to note that your right is the patient's left and vice versa. So just make sure to remember that. And so you're basically saying, again, if their rib cage contour is symmetric or asymmetric is another key thing to note during your anterior view of your OMM structural exam. Moving on, we're going to go on to the next thing here. So moving up from the actual ribs, we're going to assess the sternum. So this guy right here, with your sternum, you can use the side of your hand, like if you're doing a karate chop. And so basically what you're checking is to see if there's any pectus excavatus or carinatum. And so pectus excavatus is what happens if their sternum has kind of an inward divot and it's pointing inwardly towards the patient, so medially. And then if it's pectus carinatum, or carinatum, sorry, with this one, what you're checking is to see if that sternum is actually pointing outwards. And so if it's within normal limits or if it just appears to be flat, you would say the patient does not have any pectus excavatum or carinatum. Next, what you're going to do on this one is you're going to check the shoulder height symmetry. So you're just going to be assessing the level of the two shoulders. Is either the left more inferior to the right or vice versa, or do they appear to be neutral? So this one is shoulder height. And then moving on from the shoulders, what we're going to do next is look at the quick test. And so basically with the quick test, this is a little OMM thing where you basically will have the patient take the dorsal side of their hands and they're going to clap their hands together above their head, and they'll take the palmar sides of their hands together and they'll clap that over their head. And so this test just very quickly determines if the patient has good active range of motion in their upper extremities. So this is going to be either positive or negative. If they're able to successfully bring the dorsal and palmar sides of their hands over their head together, then this will be negative, which indicates that they do have good range of motion. Moving on from the quick test, the next thing we check is the TMJ. And so this is the joint that is just anterior of those ear canals on both sides. And so basically the TMJ is going to be right there. And so what you would do in front of your patient is you would palpate in front of their ears. You would ask the patient to open up and close their jaw. And as you're doing this, you're asking the patient, while the patient is doing this, you're checking to see if you note any crepitus. So that could be like cracks or popping, or any roughness that you're detecting on both sides. And so that would be just crepitus. So you would note that if you felt it or heard it. And then also the TMJ test is checking for any chin deviations. So those would be things like if when the jaw was fully opened, you noted that their jaw was, pointing right or left slightly instead of neutral. So that's another thing you're going to look for. Moving up from TMJ, another thing we care about here is facial symmetry. And so this is another thing where you would either note yes or no whether or not their face appears to be symmetric. Moving up from the face, we're also going to be looking at the earlobe levels, specifically the lower earlobe levels. So earlobe level symmetry. After you've assessed earlobe level symmetry, you also check the eye level symmetry. So is the left or right eye higher than the other? And then finally, what you do in terms of the head is that you're going to check and see whether or not there's any side bending. So that would be like if you tilted your head to the side like a dog does when it's confused, or any rotation of the head too. So like if the patient in their neutral position was like looking off to the left and side bent, you would just make note of that, of the head. So these are the 14 things that you're going to take just from that anterior view of an OMM structural exam. So I know it's a lot, and that's the reason why I try to encourage myself and others to be very systemic in how you do this. So just start from the bottom, start from those arches on the foot, work your way up to the knees, and then the ribs, and then that sternum, and then the shoulders, and then that quick test to check that upper extremity active range of motion. Then move on to that TMJ joint in front of the ears, both sides, and then you're also going to be checking those earlobe levels, the facial symmetry, the eye level symmetry, and that side bending and rotation of that head. So I know it's a lot, but just keep practicing it and you guys should get it. So that is what we get from the anterior view. Next up, what we're going to do is we're going to have their patient turn to their side, and this specific view is called the posterior lateral view. And so we're looking at the patient at a bit of an angle. And so from this side, the way I remember this one is SCGP. So first thing we're doing is we are looking at the following. So we care about the squat test. So what you would do from this view is you would ask the patient to try to extend or flex their knees to 90 degrees. And so if the patient can squat and keep their heels on the ground and go to 90 or more degrees of flexion in the knees. So knees squat to greater than 90 degrees. I'll try to write that clearly. I apologize for bad handwriting. So if the answer to this is yes, it indicates that the patient has good active range of motion of their lower extremities. And so what this would tell you is it would be a negative test if they're able to get past 90. If they couldn't, if they could only squat to like 50 degrees, then they would be a positive on the squat test for the posterior lateral view. Up next, C is going to be curves. So what we're going to do is we're going to look at the curvature of the spine. So we're going to have our lumbar region right here, as well as our cervical region up in the neck. And so in the low back and neck, we're expecting to see something called lordotic curvature. So this is lordotic curvature. So that's what that C is standing for. And then in addition to that, we've also got something called kyphotic curvature. And that is within our thoracic vertebra T1 through T12 of our back. G stands for the gravitational line. And so what that means is your gravitational line is this thing that whether or not that tells us the following. So what you do for this guy, gravitational, I apologize, my handwriting, gravitational line is you're going to first palpate to just anterior of the lateral malleolus. The way I remember this is it's basically that little hammer that's on the outside of your leg. So it's like just at the base, the proximal end of your fibula. And so you palpate to just anterior of that. You're also going to palpate to the patient's greater trochanter. And so if the patient sways their hips, like if this guy in front of us just swayed his hips to the right, the greater trochanter will be the most lateral thing, the most outside bony feature that we can palpate. And so what you're doing when you're assessing the gravitational line on a patient during an OMM structural exam is you're checking to see if their lateral malleolus is in line with their greater trochanter. And then you're also going to check, so you start at that guy, the lateral malleolus. You also go up to greater trochanter. And then also what you're going to do is you're going to palpate to the acromion process. And so acromion process, this is going to be the bony process of the scapula that is most lateral, and you'll be able to feel that. And then that would be the third point of reference. And then finally, in the ear canal, the technical term for this is the external auditory meatus. And so basically you've got these 4 points from the posterior lateral view that you can compare and check the gravitational line to. So what you might say is that the greater trochanter is anterior to the lateral malleolus if the patient's hips were more forward than the feet on the ground. And so like if the patient was leaning their back relative to their pelvis, you might say that if they were leaning backwards, what you would say is that their acromion process is more posterior than the greater trochanter. And then if the patient's head was extended backwards, you would say that their external auditory meatus is also posterior to the acromion process. And sometimes these can be very small amounts, but that's what you're looking for. And then finally, what does this P stand for? P is the patient's overall posture. And so with posture, if you're looking at a person from their side view, basically what you want to check is, are they leaning forward? So are they leaning anteriorly? Are they leaning backwards? That would be posterior leaning. Or are they just leaning not leaning at all, so a very neutral stance? So those would be your 3 options for posterior. So that's the 4 things you should be taking away from the posterior lateral view, is that squat test, the curvature of the spinal levels, and then the gravitational line, and finally their posture. And now what we're going to do is we're going to move on to the final bit here, which is our posterior view of our patient. And so with our posterior view, I'm just going to write this out. So this is us being directly behind the patient. What we're going to first start with is just an overall assessment of the patient's skin. So again, do we note any bruises, macules, redness, swelling, scars, anything like that? And tattoos, so if we see anything like that, we would just make note of it, so that it's documented for our structural exam. In addition to that, what we would do after our skin is we do a scoliosis test. And so scoliosis is checking whether or not we see the spine kind of curving like that. That's way too dramatic, but do we see the spine do this? would be an example of scoliosis. The way in which you're supposed to determine if a patient has scoliosis is by having them flex their head forward and then lean forward as well. So lean their trunk or the rest of their body kind of forward. And as the patient's leaning forward, you're going to be getting this sunrise view of their left and right sides because they're going to be divided by this valley of the spinal processes of their vertebra. And so if you note that one of, as the patient was hunched over and you're looking at this angle and you saw how like the left side was way higher than the right side, that would indicate that there is some kind of scoliosis at that specific spinal level. So that might be T7. And so if you did note some asymmetry between the height of their spine or the two sides of their spines of their back when they are leaning forward, you would note what level that occurred at, and then you would also ask the patient to side bend to their left or to their right. And if you see the scoliosis resolve with side bending, it would tell you that this would be a functional scoliosis. So that's something that is a somatic dysfunction that OMT can resolve. Another thing to note here is that if you didn't see that happen, it would tell you that it's anatomical scoliosis. This is the physical spine itself. There's something more stuff going on here that requires like a physical difference that's leading to it. So we've got scoliosis. Next thing you would do on a patient is you would palpate for their scapula, the inferior angle of their scapulas. So inferior angle of scapulas. So they've got a left and a right scapula. The inferior angle is likely going to be around there. And so you would just note whether or not the left or right scapula was higher than the other. Next up, what you would do from the posterior view is you would assess the patient's rib angles. So this is the part where you tell the patient to hug yourself. And by hugging themselves, what is going to happen there is they're basically going to pull those scapula or scapulae out of the way from the ribs. And then you would be able to use your hands and basically just palpate up and down the rib cage. The one on the left is more accurate, but basically you're just assessing the rib angles on both the left and right sides to note any asymmetries that you may feel. And so the step 4 from the posterior view is basically just assessing rib angle symmetry. Step 5 from our posterior view is going to be doing the iliac crest height comparison. So iliac crest height or level comparison. And so on this patient, what we could do is we could palpate. Iliac crests are probably going to be a little bit inferior to where we would first bring our hands a little bit into the patient's body, so medially, and we would press down, and then we would feel for the bone that would stop us, that pelvic bone. So that's going to be our iliac crest. And so on your iliac crest, you're going to note whether or not you feel any differences. So this would indicate if we did see a difference in height, a thing called a leg length discrepancy. So for instance, let's say our left iliac crest was around this level, and then our right iliac crest was around this level. And so I'm sorry that this is very small, but basically this difference in height between the left and right iliac crest is something that you would document. And anything greater than 1 millimeter is considered a leg length discrepancy, and whether or not you need a shim is going to be dictated by some additional limit criteria. But basically that's what you're doing during your step 5, is palpating for those iliac crests. Another thing to note that's a very important landmark when you're practicing as an osteopathic physician doing a structural exam is that when you palpate to the iliac crest levels, the spinous process that's the midpoint between these two is going to be L4. Another thing to note is that when you're at the inferior angle of the scapulas, this spinous process level is going to be T7, and then you have the spine of the scapulas, which is going to be around that area. If you palpate to that, that's going to be T3. So these are the very important landmarks to note when you are actually doing OMM structural exams. Another thing that we would do for this patient is we would have them do a hip drop test. So this hip drop test is where you basically have the patient try to bend one of their knees and then drop their hip in that direction. And so if the patient is able to achieve this, that would be a negative result, negative test result for the hip drop test. And so you would do this bilaterally, so left side, right side, yes or no. They were able to successfully complete this. And then moving on from the hip drop test, we move on to the seated flexion. There's also standing flexion. So the order in which you should do this, let me just write this correctly. Start with standing flexion. So basically, while your patient's still standing up and you've just done all these subsequent or prior tests that have required them to have been standing, you're going to palpate slightly inferior and medial from their iliac crests. And so right in this area, you should be able to feel with your thumbs, if you palpate, their posterior superior iliac spines, so PSIS, posterior superior iliac spines. And so what you would do during a standing flexion test is you would ask the patient to flex forward, and that means that they basically lean their chest forward. And so what you're going to feel with your two thumbs is there's going to be stuff sliding underneath it. And so as stuff sliding underneath it, you can feel if there's an asymmetry between the amount of sliding that's occurring between the two PSIS ligaments or bony features that you are palpating. And so you would do that while the patient's standing. You would also do this while the patient is sitting. So there's the sitting flexion test. And so with those, again, you would check whether or not you feel equal amounts of motion along the PSIS while the patient is flexing forward and extending back up. And so if you note any discrepancies between those two, that would be a positive finding on those tests. And so with a sitting or seated flexion test, the reason I call it sitting is because this indicates that you have a problem with the sacroiliac ligament. And so that's why SI, sitting, SITTING, is a helpful way of writing this test. And then if they are positive on the standing flexion test, it would indicate that the patient has an issue with their iliosacral ligament, so IS, which is the opposite. So that is the key stuff to take away from the views that you would get from running an OMM structural exam on a patient. I'm going to wrap things up with this, but I hope this is helpful. Thank you all for watching. Let me know if you have any questions, and I'll talk to you guys next time.